Good
Hello.
afternoon, Ishan.
Very good afternoon, Dr.
So,
Sukhdeep.
should we start the sessions?
Yeah, if everybody is there, I think we should start.
Hello, Sukhdeep.
Hi.
Yeah, good morning. Dr. Vinay, is your presentation uploaded, no?
Yes, ma'am.
Yes, doctor. Yes, doctor. I'm sharing the presentation.
Yeah, you can please start the presentation. You can.
Yes, yes.
Yeah.
And we have to start the uploaded presentation, or somebody will start from
No,
there.
no. They will play the uploaded presentation.
Video. Okay, fine.
Yeah. Yeah. Welcome, Dr. Ishan, for our KYS meet.
Thank you very much.
Thank you.
Hello, everyone. My name is Dr. Vinay Sultanpur. I thank organizers of the COSCON 2021 for giving me this opportunity. I will be discussing about the evaluation of Epifora. Epifora is divided in congenital and acquired, and we should always rule out the causes for the pseudoepifora. Coming to the proper evaluation of congenital epifora, so it can be mainly because of congenital dacryocele or congenital dacrostenosis, or it could be congenital fistula or congenital atresia of the puncta and canaliculi, congenital absence of the valves. So the thorough proper history is very important to know the cause and the site of the epiphora. So whether it's unilateral or bilateral, whether the epiphora is constant or intermittent, we should always know about the recurrences and remissions, discharge, whether it's a watery, mucopurulent, mucoid, or bloody type, and swelling over the lacrimal sac area, and subjective ocular surface discomfort. So in pediatric age group, thorough history is important. Depending on the nature of the tearing, we can always try to get the site of the blockage. If the tearing is constant with minimal mucopurulent discharge, the block may be at the level of punctal or canalicular atresia. If the tearing is constant with frequent mucopurulent discharge, then it could be at NLDO, complete NLDO blockage. If it is tearing is intermittent and mucopurulent discharge is frequent, then the cause could be at the nasal inferior turbinate blockage. So we should always rule out the other causes in children like ophthalmia, neonatorum, ophthalmus, epiblepharon, or congenital ectropion, and meningoencephalocele. So coming to the evaluation of acquired epiphora, so the thorough history is always important. Then we should always rule out the medications, whether it's the topical or systemic. Any previous surgery like probing, DCR, slit surgeries, any nasopharyngeal or orbital surgeries, previous radiotherapy, allergy, nasal pathology, systemic disease like vaginal, sarcoid, OCP, or scleroderma, and etc. So the proper clinical slip map examination is very important to know the tear meniscus height, state of the puncta and canaliculi, whether there is a creamy pus or any fountain type of the pus is there, and ocular surface staining to know the any ocular surface staining. Then to know the dynamics of the lid closures, lid laxity, the palpation is very important because if it is mucosal, then we can elucidate the Roplast test. In acute dacrocystitis, the usually tenderness is below the medial canthus tendon. If it is tumor, then it will be hard, and it's usually the above the middle canthal tendon, and it's usually associated with the bloody type of the discharge. We should always rule out the epiphora like trichiasis, distichiasis, severe MGD, occult foreign body, and any viral keratitis or corneal surface disorders. So coming to the proper epiphora workup, to know the punctal malpositions, rule out the obstructive epiphora, and then functional. Before a punctal malposition, look for any medial entropions, lid laxities, overcorrected ectropions, or any sinuses or fistula around the lacrimal sac opening because of chronic dacrocystitis and all. If it is obstructive, it may be mainly because of punctal stenosis. It could be idiopathic, HSV, radiotherapy, cicatricial disease, or some drugs. Canalicular stenosis is mainly because of trauma, repeated probing, and actinomycosis. NLDO, it could be a primary or secondary. Lacrimal sac, mainly because of dacrocystitis, dacrolithiasis, tumors. Primary acquired NLD obstruction, it's a idiopathic inflammation and fibrosis of the NLD, most commonly seen in age. Secondary acquired lacrimal drainage obstruction, mainly because of the drugs like most commonly the anti-glaucoma medications, 5-fluorouracil, iodine 131, and inflammations like vaginous sarcoidosis, which causes chronic fibrosing reactions around the punctum. Trauma, which involves the punctum, and multiple surgeries around the eyelid, mainly because of polytrauma to the face. Infectious like actinomycosis, nocardia, herpes, etc. And it could be because of neoplastic also, like basal cell carcinoma and all. The functional epiphora, it's epiphora in a patent lacrimal system in the absence of excess tear production of the lid or lid production. So it's mainly because of the lacrimal pump failure, most commonly seen in facial nerve palsies. So evaluation test for obstructive epiphora, it's a dye test, diagnostic probing is there, lacrimal irrigation is there, DCG, and some miscellaneous like Hornblas saccharin test or mucoregurgitation test. So for the obstructive epiphora, we can some anatomically we can do palpation, syringing, diagnostic probing, DCG, nasal endoscopy, imaging, physiological tests like fluorescein dye disappearance test, scintigraphy, Jones test 1, Jones test 2, saccharin test. Coming to the proper DDT, 2% fluorescein is installed, and we should look after 5 minutes. It's very simple and high sensitivity. It's a screening tool, especially for unilateral cases. If DDT is normal, then severe lacrimal drainage dysfunction is very unlikely. Here we can see that it's totally disappeared from here, but there is mild staining is there. But positive test indicates partial or complete obstruction, or it could be because of pump failure. False positive can be seen in dacroliths, nasal polyps, and allergy. Limitations like we can't differentiate between anatomical and physiological, or the upper or lower blocks. Don't test in suspected partial obstructions, but it's no value in the total obstruction cases. So Jones 1 is to differentiate partial obstruction from primary hypersecretion of the tears. Jones 2 identifies the probable site of the obstruction. Jones 1 is more physiological, so it's positive means patent, probably the normal. Negative, it could be anatomical obstruction, site unknown, or it could be in pump failure also. False positive can be seen in 22%. Zone 2 is non-physiological. Here the lacrimal irrigation is done and fluid collected from the nose. Positive means dye in the nose, partial block at the lower sac or duct. Negative, unstained saline, it could mainly because of punctal or canalicular obstruction. Regurgitation can be seen in NLDO or CC block. Diagnostic probing, useful in children, also therapeutic, no use in adults. So hard stops rules out CC obstruction. Soft stop means cannula stops at the lateral sac of the wall. So it indicates CC obstruction. Complete canalicular obstruction, here we can see if difficulty in advancing the cannula and inability to irrigate. If the complete common canalicular obstruction is there, then there is difficulty in advancing the cannula and reflux of fluid through the canalicular system. Complete NLDO, easy cannular placement, and mucoid reflex through the canalicular system can be elicited. Some contrast DCG, here the irrigation with the dietrazole meglumine is done. It radiologically defines lacrimal excretory anatomy. Not necessary in routine cases. Advances some like digital subtraction or CT DCG or MR DCG can be done. DCG useful, differentiate small fibrotic sac from the CC block, lacrimal sac malformations, dacrolith, lacrimal sac tumor. In failed DCRs, we can know the level of block. Scintigraphy, TN99 is used. It's physiological and more sensitive. It diagnosis of functional block can be done, and it less radiation with respect to DCG. No anatomical details visualize it. Finally, the endoscopy here, the nasal endoscopy can be done for the evaluation of the nasal and turbinates. Canalicular endoscopy, it's microcanalicular, direct end-to-end visualization of the lacrimal passages can be done, and the probable site of the stenosis can be noted. Thank you.
Thank you, Dr. Vinay. Dr. Ishan, do we have any inputs from your side?
No, thank you very much. We can go ahead.
We now invite Dr. Smita Shambhu for her talk on evaluation of ptosis. Dr. Smita?
Hello, madam. Good morning.
Yeah, good morning,
morning.
Smita. So have you uploaded the presentations?
Yes.
Yeah. Please play Dr. Smita's presentation.
Good morning. It's a pleasure to be part of COSCON 2021. I'd like to thank Dr. Ellen and Dr. Roshni for this invite. I'm Dr. Smita, and I'll be talking on evaluation of ptosis. So ptosis is a Greek word for drooping or fall, and blepharoptosis is the abnormally low position of the eyelid margin when the globe is in primary position. The most common form of ptosis that we come across in our daily practice is the acquired ptosis, and the most common cause for it is the aponeurotic form, which is a stretching or the attenuation of the LPS aponeurosis from the tarsal plate. It's usually mild to moderate and is exacerbated by chronic inflammation and surgeries. Neurogenic ptosis, the most common form is the third nerve palsy or the Horner syndrome. Myogenic ptosis, it's myasthenia gravis, CPEO. Traumatic and mechanical ptosis are other forms of acquired ptosis. Congenital ptosis, the most common is the simple idiopathic ptosis. And when it's associated with superior rectus muscle weakness, it's called the double elevator palsy. Sometimes we come across a synkinetic ptosis called the Marcus gun jaw winking phenomenon, which is with the mastication, the ipsilateral eyelid elevates. Most often, the parents themselves give this symptom, and you come to a diagnosis with the history alone. Blepharophimosis syndrome is a syndrome which comprises of congenital ptosis, epicanthus inversus, and telecanthus. History is extremely important in ptosis. As I said, you can come to a fair diagnosis with history alone. The onset and duration, variability, severity of ptosis, any precipitating factors like trauma, surgeries, previous eye disease like that dry eye, extremely important to look for dry eye and VKC. Associated conditions like jaw winking, diplopia, dysphagia, especially in myasthenia patients, and family history has to be asked in myopathies and blepharophimosis syndrome. Coming to the evaluation, the first examination that you do is the visual acuity, followed by the facial examination, abnormal head posture. Usually it's a chin lift, and also a frontalis overaction and severe ptosis. Always look for strabismus. More often you come across an ESO or an exotropia in patients who come to us, when that's a congenital ptosis, who come to us in their adulthood for surgery. And more often you also come across a pseudotosis condition, especially in hypertropias. Extraocular movements have to be looked for. Bell's phenomenon, extremely important, especially for your management. Always ever the lid and look for GPCs or floppy eyelid, symbol of Ron. These things can happen when patients can have a trauma and they wouldn't have realized that it's resulted in a symbol of Ron. So it's extremely important to look at the phonesis. All these points are important, and I'll be going through all of these in the cases that I'll be talking about in the presentation further down. Coming to the eyelid measurements, palpable fissure height is the most important, and also the first examination that you'll be doing. It's the distance between the upper lid and the lower lid margin. Margin reflex distance is the distance between the corneal reflex and the upper lid margin. Lid crease height is the distance between the upper lid margin and the most prominent lid crease. So this is usually around 10 millimeters in females and around 7 millimeters in males. And it's extremely important because your incision is placed on the lid crease or your where the patient wants the future lid crease to be placed, especially in a bilateral ptosis. This is how you do the LPS function, that is by Berg's method, negating the frontalis action by pressure over the eyebrow and look for the excursion of the upper lid from down gaze to up gaze, and it's measured with the help of a ruler. And this is how we grade the ptosis. In congenital ptosis, it might be a little difficult to do all these measurements. So what we do is upper eyelid of the child is everted. And when the child looks down, if the levator action is good, the lid reverts back to on its own. Always look for pseudotosis. It's important to differentiate between a false ptosis and a true ptosis. Coming to some of the cases, this child had a severe left ptosis, and to prevent amblyopia, you would want to do this surgery at the earliest. Here it was a frontalis sling because of poor LPS function. This is the same child after 3 years, and the lid lag persists. This can happen with sling, and this has to be explained to the patient, and that's the reason why Bell's phenomenon comes into play here, especially in children. If it is poor, you would want to place the upper lid at a little lower height. And it's important to manage both. That's the amblyopia as well as the lag of thalamus that can happen if there is poor Bell's, and also there can be exposure keratitis. Congenital ptosis, another patient who was around 4 months of age, and she had already started developing amblyopia. So what was done was an ethibond suture was placed, which can be replaced with a sling after about a year's time. This is a classic case of epineuritic ptosis with the increased lid crease height, frontalis overaction, and she also happened to have lag of thalamus. This is post-surgery. As the right eye is elevated, the contralateral eyelid droops. This is due to Herring's law, and this has been explained to the patient. It's very important that you also explain that there can be exposure keratitis, especially in patients with lag of thalamus. You would want to undercorrect here and also take care of the exposure. It usually reverts back to normal after about a week's time. So she is a case of right congenital ptosis, but she also had an esotropia, which became more evident post-surgery. It was an LPS resection, but the patient did not want a strabismus surgery. She was fine with the small amount of strabismus. But it's important that you make the patient aware of this, and more often it is the strabismus surgery which is done first, followed by the ptosis surgery. Patient was referred for evaluation of ptosis. Is there a ptosis? Was not sure, but the patient pupil was dilated due to tropicamide plus. So the patient was called back for evaluation the next day, and this was it was quite a severe ptosis. What's important here is that the evaluation of ptosis has to always happen in an undilated pupil. This is a case of a left severe ptosis with frozen globe, and this is her CT and MRI. So what happened was, this is a case of rhino-orbital mucormycosis. Many of patients actually came to us with ptosis and third nerve palsy. I think many of us have come across such cases earlier this year during the epidemic of mucor. I didn't need to exenterate here. She improved with transconjunctival amphotericin, and she's doing fine. It's been about 7 to 8 months now. This is a case of chronic progressive external ophthalmoplegia, and when it's associated with pigmentary changes in the retina, it's called the Kearns-Sayre syndrome. This patient came with actually a left proptosis, and he had features of thyroid orbitopathy. But the same patient presented again after a month's time with the opposite, that's the right eye ptosis. And fatigue test was positive, eyes test was positive. He had raised antibodies for acetylcholinesterase enzyme. So we started him on steroids and pyridostigmine. Right eye ptosis improved, even the left eye proptosis also improved. So what's important is that we keep in mind that these two conditions can overlap, since both are autoimmune in origin. So this is a case of pseudotosis due to blepharochalasis, and this is a case of true ptosis due to blepharochalasis. And you can see the upper lid in the left eye, the skin has become really thin. This is a classic appearance of cigarette paper appearance. And these patients can have recurrence. So it's always better to defer surgery for up to around 6 to 8 months. of a disease-free period. And post that, we did an LPS dissection with blepharoplasty, and she's doing fine as of now. So I'd like to end with this take-home message, that is, ptosis itself is merely a physical sign and not a diagnosis in itself. And it's important that we do a good history and evaluation to come to a diagnosis, since our management depends on it. Thank you.
Dr. Chinmay, I would like to
yeah.
point out a couple of
Yes.
points.
Please.
One thing I would like to examine, especially in aponeurotic or senile ptosis, is palpebral fissure with in extreme down gaze. Because many
Yes.
patients, they come to us and they say that while we read, just after 15-20 minutes, the lid droops down.
Yes.
Patient may not have actual ptosis in primary gaze, but when they read, the levator cannot sustain the lid in down gaze, and so they have complaints. So less than 2 mm is really significant, and patient may be advised for ptosis correction.
Yes, it's a very nice point that you mentioned, Dr. Ishan, because for many of them, it's a functional problem, particularly in down gaze, and we just examine mostly for the primary position ptosis. Very point nicely taken. Yes.
Another point is double lid crease, in especially in the congenital ptosis. Sometimes we have double lid crease, and the other eye is absolutely normal. It has single lid crease only, and we may get confused that where to put incision. So we have to have a very proper examination from up to down gaze, and which lid crease is prominent and goes laterally till the canthus, so that we can decide the incision, because otherwise there will be asymmetry. So that is also to be taken.
So most of the times our patients will be very satisfied with the lid height, but they will not be satisfied with where our crease is present.
Yes.
Particularly with females. Yes. So these are very two nice points given by Dr. Ishan. Thank you very much, sir. I now call upon Dr. Sukhdeep to give her presentation. Dr. Sukhdeep, you have uploaded the presentation?
Yes, Dr. Chinmay, it's uploaded.
Yeah. Can we have her presentation, please?
Good afternoon, everyone. I thank KOS for giving me this opportunity. I will be discussing the basics of evaluation of proptosis. I shall be covering the topic under the following headings. Proptosis is derived from the Greek word propektein, which means to fall forward. It is defined as an abnormal protrusion of a normal size globe beyond the boundaries of the bony orbit. Another term that we use is dystopia, that is displacement of the globe in the coronal plane, which mostly happens because of an extracorneal orbital lesion. Bony orbit is a non-expansile closed space, and any increase in demand is accommodated by the pushing forward of the anterior structures, that is proptosis. The problems that are seen in proptosis are the affection of the optic nerve, which leads to a decrease in the vision and the coloration. Exposure keratopathy is seen because of decrease in the blink rate and lack of thalamus, leading to corneal ulcers. Diplopia can happen because of the displacement of the globe, as well as the increase in size of the extraocular muscles, causing extraocular muscle dysfunction. The causes of proptosis may be manifold. Infection, cortical cellulitis, mucormycosis, which we have seen to be the most common cause recently, tumors, and also vascular causes like keratoconus fistula. Proptosis can be classified according to the direction, onset, laterality, and whether it is pulsatile or intermittent. Proptosis is axial when the protrusion is seen in the anterior posterior direction, or it can be non-axial in the direction opposite to the causative lesion. A false impression of proptosis or pseudoproptosis can be seen in enlarged globe because of ophthalmos or high myopia, lid retraction, facial palsy, cicatricial changes, or in cases of a shallow orbit. History of vision loss, diplopia, and pain should be assessed. The duration of the disease concerning the mode of onset and progression is an important indicator of the cause. Acute proptosis is most likely to be because of infective or inflammatory causes. History of trauma and the sound of bruit may be an indication of a keratoconcaverous fistula. In cases of rhinological etiology of proptosis, there can be symptoms of epistaxis or nasal blockage. History of systemic diseases, including family history, should be taken. For example, thyroid. A physical examination should not be limited to the eye. A cachexic build indicates a chronic condition or metastasis. A skull abnormality might be indicative of a craniosynostosis. A neck swelling might be related to a thyroid gland. The inspection should be done so as to ascertain the direction of proptosis, any lid retraction, any visible mass or congestive features in the periocular area, blood vessels that are visible in the eyelids or visible pulsation or any corkscrewing of the conjunctival vessels. Palpation of the orbital margin should be done to assess any irregularity or tenderness or a swelling might be palpated. Reducibility is mostly seen in the early cases of thyroid-associated eye disease or in vascular causes. Pulsations occur when a vascular pulse transmitted to the orbit and is seen in increased vascular turbulence. Another maneuver that we perform is asking the patient to bend forward and cough. This increases the intraorbital pressure, and increase in proptosis is seen mainly in cases of orbital varix. An assessment of vision and coloration should be done at the first visit and at each subsequent follow-up. Pupils should be seen to ascertain for any relative afferent pupillary defect, which might be the early indicator of a compressive optic neuropathy. Fundus examination may show us optic disc swelling or disc atrophy, retinal hemorrhages, choroidal folds, or optociliary shunt. Extraocular muscles should be assessed in all cardinal directions of gaze. Objective assessment of proptosis can be done by asking the patient to look up and looking from below, that is a worm's view, or standing behind and asking the patient to look down, that is the bird's view. Subjective assessment, Hertel 6 ophthalmometer is used. The normal reading is considered to be less than 21 millimeters or a difference of less than 2 millimeters in between the two eyes. In the absence of a Hertel ophthalmometer, a simple plastic ruler can be placed at the lateral canthus and the amount of protrusion be read off the markings. Similarly, a Lewis 6 ophthalmometer has a notch that sits on the lateral canthus and the amount of protrusion is read off the markings. An appropriate imaging like a CT scan or an MRI can be requested. These are the masses that we typically see in particular areas. So if we see a supraronasal mass, it's most likely to be a dermoid or a mucocele or a metastasis. In a superotemporal area, the lacrimal gland is most likely to be involved, and fullness in the temporal fossa is indicative of a sphenoidic meningioma. To conclude, evaluation of proptosis needs a methodical approach, including inspection, palpation, auscultation for a bruit, and examination of the patient as a whole. Optic nerve signs like vision, coloration, and pupil examination should be looked for. An appropriate imaging should be requested to start the best line of management. Thank you for your patient hearing.
Thank you, Dr. Sukhdeep. Dr. Akshay, your presentation is loaded.
Actually, I'll present it live. I have not been able to upload it.
Yeah.
So I'm Dr. Raksha. I'll be talking on interpretation of CT and MRI scan. So CT or MRI scan is indicated for various reasons in the evaluation of orbit, including any trauma, evaluation of proptosis, evaluation of disc edema, or in the evaluation of congenital and developmental anomalies. So based on the anatomy of interest, for any bony wall and paranasal sinus evaluation, a CT scan is preferred, while optic nerve evaluation is best done by MRI scan, and for globe, it is the ultrasound or the MRI scan. For any orbital mass lesion, a CT with or without contrast is adequate in most lesions. However, an MRI is a problem-solving technique which is useful in any lesion of uncertain tissue of origin or those which have an atypical appearance on CT scan. For assessment of any vascular lesions of the orbit, an MRI with or without DSA will be necessary. For retinoblastoma or for any disease activity follow-up, an MRI is the most preferred diagnostic modality. In certain cases, both CT and MRI scan is necessary. If, for example, craniosynostosis, where CT is important for the evaluation of shallow orbits or bony abnormality, while MRI is also indicated in the assessment of the optic nerve status, hydrocephalus, or any brain parenchymal abnormalities. An MRI, however, is absolutely contraindicated in the evaluation of any suspected intraorbital foreign body in the fear that it might be a metallic foreign body. For example, in this patient with a history of cylinder blast injury, where a CT scan confirmed the presence of a metallic foreign body. So while a person is handed over a film, whether it is a CT or an MRI scan, you differentiate it with these features, because in CT scan, the bones are very prominent, including the nasal, orbital, and cranial bones, whereas in MRI scan, the brain is more prominent with the appearance of sulci and gyri individually seen, as also the optic nerve and the optic nerve sheath, in contrast to the CT scan, where the brain appears as a soft tissue density mass, and so does the optic nerve without the appearance of the optic nerve sheath. So whenever you evaluate a CT or an MRI scan, you always compare the symmetry between the left and the right orbit. As in this patient, where you see the left orbit is smaller, so is the eyeball, which makes the diagnosis of a congenital or an acquired microphthalmos or enophthalmos extremely clear. So when you describe a lesion in a CT scan, you always describe in terms of density. For example, for any lesion that is in the grayness that is similar to the muscle, you call it as isodense, and anything that appears brighter than the muscle, you call it as hyperdense, and anything that appears darker, you call it as hypodense. So the density of a lesion can also be described in terms of Hounsfield units, which a radiologist must share on a film that you are receiving. For example, in this patient with a left orbital mass, you see the Hounsfield value given by the radiologist is -90. And when you compare it on the scale, you see that this lesion is a fat containing lesion, and depending on the location, you're able to pinpoint this lesion to be most likely to be a dermoid cyst. Again, in this particular patient, where you see that the Hounsfield unit given by the radiologist is +850, and based on the Hounsfield unit scale, this lesion appears to be containing calcium. So on clinically correlating the lesion, it appears to be an arteriovenous or lymphaticovenous malformation with the phlebolith within the lesion. So whenever you view a CT or an MRI scan, you need three scans, three views: the axial, coronal, and the sagittal view, which helps in pinpointing the exact location of the lesion. For example, in this patient who has a foreign body, you are able to pinpoint the foreign body to be located within the soft tissue mass and in the inframedial orbit. When you're assessing a posterior orbital fracture, you always ask for CT cuts to be of 1 millimeter cuts so that you can assess any bony impingement or a soft tissue impingement that is compressing the optic nerve. Also, in the evaluation of an orbital fracture, you ask for a bony window, which highlights the bony details, including sutures and any small fractures, as also a 3D reconstruction, which provides an overview of the bony pathology that can simulate the intra findings. So the CT scan, like I mentioned, a bone window can highlight any small fractures and the bony details. A soft tissue window, on the other hand, highlights any soft tissue mass within the orbit. CT scan with contrast is necessary for the evaluation of most orbital lesions. For example, this elderly lady who presented with soft tissue edema, you see that the plain scan provides a picture of a very irregular mass in the superior part of the orbit, and on contrast scan you see what is evident is in a dilated superior ophthalmic vein. So this lesion is likely to be an arteriovenous malformation with sudden thrombosis that has led to tissue edema. A CT scan also can be used for the evaluation of proptosis. Clinically, of course, this patient appears to be a thyroid eye disease with proptosis. On CT scan, you diagnose proptosis by drawing a horizontal line across the equator of the globe. This line, if it is beyond, this has to be in a mid-axial section, and if this line is beyond the lateral margin of the lateral orbital wall, you can diagnose it to be proptosis. And in thyroid eye disease, the muscles appear enlarged and there is sparing of the tendon. In patient number 1 here, you see that there is a superior temporal orbital mass, but this particular mass, which is in the region of lacrimal gland, does not appear to be causing any bony erosion. Also, this particular mass doesn't seem to cross the midline. So most likely this is a benign orbital lacrimal gland lesion, most likely pleomorphic adenoma of the lacrimal gland. Whereas if you see the patient number 2 here, you see that this particular orbital mass of the lacrimal gland has crossed the midline, as also it has caused some bony erosion. So most likely this lesion appears to be a malignant lesion, most likely an adenocarcinoma of the lacrimal gland. On the other hand, MRI orbit, if you see that this patient who presented with the left proptosis, you see that CT scan shows an irregular mass in the extra and the intracorneal space, whereas the same child, the MRI scan, there is a fluid level, and hence MRI scan is very useful in characterizing the lesion and helping in reaching a diagnosis even before a biopsy is mandated. So in terms of describing a lesion in the MRI, you talk in terms of intensity. So anything that is in similar grayness as the muscle, it is supposed to be iso-intense. Anything that is brighter is hyper-intense. Anything that is darker is hypo-intense. And mainly there are 2 sequences, T2 and T1. In T2, the vitreous and the CSF appear hyper-intense. In T1, the vitreous and the CSF appear hypo-intense. But you see that in T2 and T1, the orbital fat also appears hyperintense. So for any lesion that requires assessment within the orbital fat, you need to suppress the orbital fat, and you do so by using a sequence called T2FS, which suppresses the fat, and the fat, as you see here, appears darker and the lesion stands out. So most of the T2 lesions are hyperintense. So you need, in T2 sequences, you need to look out for lesions that are hypointense, and these are usually lesions that contain melanin or bony calcified lesions, or a hemorrhagic lesion that is acute or chronic, or fungal infections. Similarly, in T1, the orbital fat appears hyperintense, and you need to do a fat T1FS to suppress the fat, and most lesions would appear hypointense. So on T1, you need to look out for hyperintense lesions, which are usually lipid-containing lesions, subacute hemorrhage, lesions containing proteinaceous contain melanin or mineralization. and hence in choroidal melanoma in T2 it appears as hypo-intense, and in T1 it appears hyper-intense, and this helps in diagnosing pigmented choroidal melanoma very easily. In thyroid eye disease, an MRI scan, obviously in T1 it can show enlarged thickened muscle with the tendon sparing. However, in T2 scan it can show hyperintensity of the muscles, which corresponds to tissue edema. So this can help in identifying which of the thyroid eye disease patients are actually having active inflammation. In retinoblastoma also, MRI orbit helps in identifying any thickening of the optic nerve, as also any scleral breach, where you can identify that the intraocular retinoblastoma has now become an orbital retinoblastoma. MRI is also helpful in evaluating optic neuritis, which appears as a hyper intense lesion around which is corresponding to the involvement of the optic nerve sheath. So whenever you need a CT or an MRI scan, you must always specify to the radiologist what you're expecting from the imaging, so that you are able to narrow the differential diagnosis, prognosticate before biopsy to help counseling the patient better. Thank you very much.
Thank you very much, Dr. Raksha. That was an excellent talk, giving a wide range of orbital lesions. Thank you very much. I hope it was very beneficial. Thank you. Next, I would like to invite Dr. Ishan Acharya. Dr. Ishan Acharya is our guest speaker. He is from Baroda. And Dr. Ishan will be speaking on radiofrequency surgery. So Dr. Ishan has a very good scientific acumen, and we have been seeing all his talks in the OPI meetings. And he is from the Orbit Eye Hospital, and he was also with Taraprasad Eye Hospital there. And I've heard a lot personally from Dr. Kavita, Dr. Ishan, about your lacrimal surgeries, how easily that you do all the surgeries and Orbit in the TVPI. Over to you, Dr. Ishan, and thank you for accepting our invite to Karnataka. Thank you so much.
Thank you.
Very good noon to all. Thank you, Dr. Roshmi, and the organizing team of KOS. I feel honored to be here. My talk is on radiofrequency surgery. Electrocautery or thermal cautery carries the same meaning and uses direct current. Current does not enter patient's body. Only heated wire comes in contact with tissue. Let us know what is radiofrequency, because that is the term which is misguiding us all. This is the whole electromagnetic wave spectrum. The radio frequency is a name given to a part of this wave spectrum in which the frequency ranges from 30 kHz to 300 GHz. Let me zoom in. Therefore, principally any cautery machine using electromagnetic waves with frequency between 30 kHz to 300 GHz is radio frequency. Available ESU in market operate between 200 kHz to 400 MHz. Why? Because frequency less than 100 kHz causes muscle and nerve depolarization. So it is absolutely a myth that only high frequency unit is radio frequency. All modern electrosurgical diathermy units are radio frequency unit. In electrosurgery, the patient is included in the circuit. It enters via electrode in the patient's body and exits through the dispersive electrode. In bipolar, current flows between the two poles of the forceps and it does not need dispersive electrode. These are thermal effects while using an ESU. If cellular tissue temperature reaches 50 degrees centigrade for 6 minutes, cell death occurs. If the temperature reaches 60 degrees centigrade, cell death occurs instantaneously. If temperature is between 60 degrees centigrade to 100 degrees centigrade, cell death occurs by desiccation, that is dehydration, and protein coagulation, known as white coagulation. When the intracellular temperature reaches 100 degrees centigrade, cellular vaporization occurs, and that is believed to be responsible for cutting. When reaches 200 degrees centigrade or more, the organic molecules are broken down in a process called carbonization. These create a black appearance referred to as black coagulation. We use ESU without necessarily understanding the fundamental principles of function. These factors are ESU dynamics, and every surgeon must know all. These factors finally work through current and power density. Let us understand. Sunlight on a surface has a different effect when it is focused and unfocused. Current or power density operates similarly. Very high current density concentrated at the tip of an electrode can be used to heat and vaporize cells. Slightly lower current density may desiccate and coagulate, while the same current spread over a large area may have no impact on the cells, like in case of using a dispersive electrode. So again, it is a myth that tissue effect or healing is dependent on the frequency at which an ESU operates. A typical ESU displays digits, which is controllable, and it is indicative of power, and different modes and sub-modes that are changeable. These displayed parameters, when changed by a surgeon, changes the undisplayed parameters, thereby affecting the output of an ESU, that is current or power density. Each company has its own way of displaying modes and sub-modes, and also the output characteristics vary with peak voltages and other variables. We must understand the dynamics of this change. One must be familiar with all these terms. Voltage is the force of electrons and generated at the source. Ampere is the flow of electrons through the system. The resistance to flow is measured in ohm. What is the final effect after the interplay of all these above is power. Duty cycle is the generation of alternating current for percentage of time that takes to complete one circuit. If an ESU generates current for 80% of the time and keeps it off 20% of the time, it is known as 80% duty cycle. Tissue effect vary with waveforms. In figure, if you compare 50% duty cycles with 6% duty cycle, you can see that the peak voltage rises. This is due to the ESU is trying to maintain constant power, which is set by the surgeon, because of off time of current, because of variability in the duty cycle. Cutting is best achieved by a waveform consisting of 100% duty cycle, non-modulated continuous waveform which has peak voltage of more than 200. Blended waveform is produced by duty cycles of ranging from 30 to 80%. Coagulation waveform is modulated, high voltage but dampened, meaning the peak voltage decreases like this. See, it will be like this. It is not that the single waveform functions as a cutting waveform or coagulating waveform. In the photo, we can see the change in the cutting, coagulation and lateral damage with change in the duty cycles and thereby waveforms. You can see the 6.3 duty cycle, 25% duty cycles, 4.8% duty cycles, and you can see the effect of this on the tissue. So we must go through the manual of the manufacturer to see undisplayed pure monopolar cutting mode in these machine operates at maximum 400 watt at 300 ohm resistance. It gives information about the waveform, peak voltage, crest factor, and Crace factor is directly proportionate to the ability of the machine to coagulate. All ESU can track an impedance baseline and subsequent changes in the impedance. If I set watt at 25 in pure cut mode, the ESU will adjust the voltage such that it delivers maximum output of 25 watt only. If suddenly the electrode encounters high tissue impedance, the machine will increase the voltage as per algorithm. This may or may not be beneficial in cutting the tissue, and the surgeon may have to increase the power to bring desired effect. If the power is more than required for the tissue, it will increase collateral damage. This is known as power curve, and it is one of the most important technical data which a surgeon must know. It is a representation of how a particular power output is designed to react to change in tissue impedance. Usually, power is delivered to a tightly controlled and fairly constant range around the selected power settings. We as an oculoplasty surgeon usually do not require power more than 50. Our tissue impedance does not change much. So, the ESU functions quite efficiently and delivers power constantly. In graph, we can see that if power is between 150 to 200, the machine gives the same output constantly up to 300 ohm, that is 300 impedance. But after that, the power output will decrease. This is the detail of each mode for the machine given in the manual. We must read and understand. I am incising at pure cut mode. The power is set at 30. See that it is not cutting very satisfactorily. Now if I keep it at 60 watts, you see white coagulation and also some charring and black coagulation. If I decrease it to 40, I get fair cutting without unintended coagulation. Soft monopolar coagulation was set at 30 watt. To cut deeper tissue, I am using blend mode for cutting. The power is 40. Here the duty cycle changes, and which can be seen in the manual itself. The machine will not tell you what is the duty cycle. Now to cut the periosteum, I am using broader electrode and blend mode. So we have to learn which power setting is most appropriate for a particular step in our surgery. Current and power density are inversely proportional to the size of electrode. Increased current density or power density will require less power setting, thereby reducing collateral damage. Striker tips are very suitable for our oculoplastic surgery. The electrical properties of the media, air, water and saline etc. around the active electrode are included in the electrical circuit, especially if the electrode is held off the tissue, that is near contact. Consequently, the impedance in a steam envelope or plasma cloud or ionized gas is much lower than that of air. This will increase current density. But saline or blood around the active electrode can make it function like a dispersive electrode, thereby decreasing power density. So, saline or blood must be soaked if we want to improve performance. Tissue with high water content has lower impedance. Tissue such as bone, callous skin or fat or any previously desiccated tissue will impede passage of current and therefore will inhibit creation of an electrosurgical effect. If it is necessary to cut through tissue with relatively high impedance, increasing the voltage by raising the power output or decreasing the duty cycle is usually effective. So it is up to surgeon to understand some of the principles of thermal change. Three goals of applications are definable: limited thermal change to target tissue, adequate hemostasis, tissue cutting and vaporization. To maximize these goals, intuition alone is insufficient. Thermal effect is directly proportionate to the current density, tissue impedance, time of application, and inversely proportionate to the area of application. Now, these must be learned by heart and applied while using an ESU. The goal of surgeon is to concentrate the current only at the target tissue and avoid concentration at all other points of the circuit. The speed of cutting electrode must be optimized to the settings. Surgeon should use sharpest electrode possible. Watt should be kept as low as possible and he should refrain from simply increasing the power. More concentration should be to make field dry and stretch the tissue. This is the book from which I have taken the reference material. We must read it if we are using an ESU. So, electrosurgery is a constantly used but commonly misunderstood technology. Many variables contribute to the final tissue effect by contributing to the current density. Surgeons must know the physics in general and also with respect to the machine he uses. Thank you.
Thank you very much, Dr. Ishan. That was a wonderful lecture. And after a long time, we are hearing the physics. Normally, we'll be hearing physics of phaco machine and other things. And this is one of the best lectures that I've ever heard. And I also really appreciate the fact that you stress that intuition is not just enough. It's so many times it's just gut feeling that we are taking. But having a deep understanding of how the way the machines work and all that, it's really going to help us to do much better work. Thank you so much, Dr. Ishan. Do we have any other comments from the other speakers for Dr. Ishan?
Anybody has any question?
Any questions or comments to make? Dr. Raksha, you have anything to add? Okay. I think I really appreciate you taking time off for this keynote address. Thank you very much, Dr. Ishan. And
thank you.
Yeah, thank you. We now move to the vast enucleation and evisceration by myself and entropion and ectropion by Dr. Mopia. Can we have the presentations, please? Hello everyone, this is Dr. Chinmay from Minto Ophthalmic Hospital. Today I will be speaking on enucleation and evisceration surgeries. As we all know, these are destructive procedures and the indications for these surgeries are mainly malignancies, infections like evisceration, endophthalmitis and panophthalmitis. Sometimes in very severe trauma when the eye is grossly damaged or in painful blind eyes also, these procedures are considered. Earlier, the indications were very strict. However, now the indications are overlapping, but there are absolute indications and absolute contraindications for each other. So the absolute indication for enucleation is malignancy, and the absolute indication for evisceration is infection like endophthalmitis and panophthalmitis. So these two should not cross over. Okay, you cannot do an evisceration in malignancy. We cannot do a enucleation in kind of infections like endophthalmitis and panophthalmitis, as the infection could later spread into the meninges through the optic nerve cut end. And that is why these absolute indications for each other become absolute contraindications for the other. Rest of the time, these indications are kind of overlapping. Earlier days for painful blind eye, enucleation would be considered, but nowadays most people preserve evisceration. As long as the cornea is removed, which is the main sensory apparatus of the eye, the pain is basically from the cornea. So once you remove the cornea, the pain impulses are much better. So evisceration gives a much more better cosmetic results in terms of motility, and that is why we prefer evisceration over enucleation. And with the advent of the split sclera techniques, the size of the implant that could be placed for evisceration cases are also larger. Okay, let us see the video of enucleation. And before we do any of the procedures, always ensure if the surgery can be withheld. Like most people, if they're thinking of cosmetic reasons, try and see if you can do any kind of cosmetic shell, the scleral shell on the thicical eye, because that gives a much more better results. And also consent to surgeon's opinion, all that has to be noted, and a photographic documentation also must be taken before we do the procedure. And this is the enucleation procedure that's being done for a retinoblastoma. As you can see here, the conjunctival peritome is done 360 degrees. And here we can note that I have already done the lateral canthotomy. So this lateral canthotomy is basically useful to get a long optic nerve stump. And now in the medial rectus muscle. And here during the entire procedure, try not to get too much bleeding, as the bleeding will cover your visual, like the field of the surgery. Sometimes because during the entire procedure there should be no globe perforation, because that would amount to seeding the tumor. So ensure that it is bloodless so that you have good visibility during the surgery. And you can see that I am hooking the inferior rectus now, and at all time I am leaving a larger stump so that I can hold the stump and pull the eyeball up when we are doing the enucleation. We can do a myoconjunctival technique when these muscles are sutured into the fornix. So now the inferior rectus is disinserted. Similarly, we will disinsert the lateral rectus and the superior rectus. Okay, so once these are all cut, so other additional tenons tissues which were attaching, those are all disinserted. And now I'm going to clamp the lateral rectus. And similarly, clamp the medial rectus. You can also suture the muscles and pull the globe up like this. See here, our main intention is to get a long optic nerve stump. At least 15 millimeters of optic nerve stump is required in the retinoblastoma cases. The other cases, you don't need a longer optic nerve stump, but then as I told you, the indication is mostly malignancy now. So definitely going for a longer optic nerve stump. So this gives traction and pulls the optic nerve. The S-shaped contour collapses into a straight line, and that's how you will get a longer stump. You can cut through the lateral approach or through the medial approach. Here I'm using the lateral approach because we have done this lateral canthotomy and it's easier to go in from this side. You could also do the same from the medial rectus approach as well. So you will just slide along the optic nerve and you will get the feeling of the optic nerve. And when you cut, you will definitely get the grating sensation, and it just comes out with a snap like this. Now you can see that the whole eyeball has come out. Okay, once the eyeball has come out, we have to examine the eye for any perforations, or if there are any enlarged blood vessels, or if there is any area of scleral thinning. You can have bleeding like this, and this bleeding will usually get controlled with pressure itself, and then an implant will be placed, and you will close it. The closure I will explain to you during the time when I'm showing the evisceration technique. Okay, so now we will see the evisceration surgery. So evisceration surgery, as I told you, is going to be much easier, I would say, because in the evisceration, sorry, again the enucleation is playing. Wait a moment, please. So in the evisceration, the main intention is that we will be not removing the whole eyeball, but we will be retaining the sclera. Yeah, so now we will be seeing the evisceration surgery. In the evisceration surgery, you can see that this is for a painful blind eye. So a 360-degree peritomy is done. Here, I'm taking care now to preserve as much conjunctiva as possible. In both the surgeries, we have to preserve as much conjunctiva. And here I'm taking a incision just after the limbus, about a millimeter after the limbus. So this will ensure that the iris comes out easily. If you are taking at the limbus, the iris gets stuck to the root of the iris, and that may cause some difficulty. So if you take a millimeter away, it's easier. And I'm using the evisceration scoop to first separate. Before that, you can use a cyclodialysis spatula to separate. And with that, the whole contents are just removed out. So now you can see that this is the entire content of the eye that has come out nicely. And the remaining uveal tissues is what poses threat for sympathetic ophthalmitis. I am denaturing it with alcohol, absolute alcohol. Just put few drops into the eye. You can use a cotton bud like this and denature all the uveal tissue and try and remove. Now I am cutting the sclera at two areas. So the anterior sclera is split into two areas. I just cut it, snip it like this. And now around the optic nerve, I have cut the sclera. So you can see that the optic nerve is in the center, and around the optic nerve, I have just made an opening and then did another two sclerotomies. So 4 sclerotomies were made and the implant is inserted. So the sizing of the implant is important. So once you put the appropriate size, it should disappear inside. So the purpose of these sclerotomies are to put a larger size implant. And now we are closing the sclera in a double breasting manner. The posterior sclera, that is around the optic nerve, whatever sclera was there, that is being closed. I'm using a 5-0 Vicryl. Please note, we cannot use sutures thinner than that because they don't have adequate tensile strength. So we have to use a 5-0 absorbable Vicryl sutures. And the posterior layer is closed. Now I'm closing the anterior layer. So, okay. So it is a double layer closure. So this is the posterior layer closure. And now this is the anterior layer closure. So these two layers are closed. Again, you can see the double breasting. So that is the way the sclera is closed. So this prevents exclusion of any implant. So that way your evisceration is superior to enucleation, that there are two layers. And also since the muscles are all connected to the sclera, the motility is transferred to the limbs. So preferred surgery is always in evisceration. You have to ensure that the uveal tissues are removed. So sometimes when the indication was for some inflammation, long-standing inflammation, the iris could have been adherent for a longer time. And then we will be closing the conjunctiva with the 6-0 Vicryl. So this is a continuous 6-0 Vicryl that's being placed. So that is the whole thing. And after both the surgeries, very, very important is not to do a nice surgery, but immediately after the surgery, you have to put a conformer. If you don't put a conformer, it's going to shrink, and the whole purpose of the cosmetic part goes away because it will get converted into a contact socket. So always ensure that you place a conformer, and most of the complications like infection, bleeding, and all are controlled. Major complications with evisceration is sympathetic ophthalmitis. However, I have never seen a sympathetic ophthalmitis occurring post evisceration, and almost all reports are also mentioning that the risk is so low that we would prefer evisceration over the implantation. And implant extrusion, migration, and all can be controlled very well if you do your primary surgery well. If your primary surgery is very good, I don't think you will have any kind of complication. Thank you very much for your patient hearing.
Thank you very much, Dr. Chinmay.
Thank
was very
you.
good presentation.
Dr. Ishan, any points? Please highlight if there are any points to be made.
Good afternoon, everyone. I thank the Scientific Committee of KOS for the opportunity. I will be speaking on entropion and ectropion. The stability of the lower eyelid depends upon the strength of the lower lid retractors, medial and lateral canthal tendon, the balance between anterior and posterior lamella of the eyelid, Entropion is mainly of two types, involutional and cicatricial. During examination, we should look for cicatricial changes in the conjunctiva. We should look for a transverse ridge of muscle caused by preseptal orbicularis overriding pretarsal orbicularis. In children, congenital entropion should be differentiated from epiblepharon. During examination, we should grade lid laxity by doing lid distraction test, snapback test. We should check for laxity of medial cancel tendon and lateral cancel tendon. There are two main procedures for involutional entropion. One is the Weiss procedure and the second is the Jones procedure. We should assess the horizontal lid laxity, and if present, then lateral tarsal strip procedure has to be combined with these procedures. I am thankful to Dr. Roshmi for this video. This is a surgical video showing Jones procedure. As you see that the lid skin is being marked about 2 millimeters below the lash line along the entire length of the eyelid. Lid traction suture is taken to pull the eyelid upwards, which would facilitate the surgery. Skin incision is being done with 11 number blade. Dissection is done meticulously in the suborbicularis plane to expose the orbital septum. The orbital septum is cut in the entire length of the incision to expose the orbital fat and lower lid retractors. This is a lower lid retractor, and 6 vicryl sutures are passed through the lower lid retractor to the inferior border of the tarsal plate and the back again to the lower lid retractor to create a horizontal mattress suture. This is a central suture, and a similar suture is taken, one laterally and one more medially. Thus 3 horizontal mattress sutures along the entire length of the eyelid. A thin strip of skin is excised to cause extra eversion of the lash line, and the wound is closed in the usual manner. This is before and after of correction of involutional entropion. In case of cicatricial upper lid entropion, the severity and thickness of the tarsal plate is important. In upper lid cicatricial entropion, if it is mild to moderate, then anterolamellar repositioning can be done, in which lid crease incision is given. Dissection is done in the suborbicularis plane to expose the tarsal plate. Another incision is given in the gray line along the entire length of the eyelid to a depth of about 2 millimeters, and then the anterior lamella is shifted upwards in relation to the posterior lamella, and then lid everting sutures are taken, and this is 1 week after and this is 1 month after the procedure. Tarsal wedge excision is another surgery for mild to moderate upper lid entropion when the tarsal plate is of adequate thickness. I'm thankful to Dr. Roshmi for this animation and the next video. Here you see a slice of the eyelid is taken off, and the wedge of tarsal plate is taken off, and once the wedge is sutured, then the eyelid everts and the entropion gets corrected. And here is the surgery. Lid crease is marked about 5 to 7 millimeters above the lash line in the center of the tarsal plate. Then dissection is done in the suborbicularis plane to expose the anterior surface of the tarsal plate. Then with the radiofrequency cautery, a ridge is created along the entire length of the tarsal plate, as you can see here. Here you can see the creation of the ridge, which is a wedge. And then horizontal mattress sutures are passed between to bring together to oppose the two edges of the wedge. And during passing of the suture, we should be careful not to perforate the tarsal plate fully, not to perforate the tarsal plate. And we should evert the eyelid and check, as you can see it being done. Horizontal mattress sutures are taken, and then a thin strip of skin is excised. This would cause a little more eversion of the lash line. If upper lid cicatricial entropion is severe, then we need to insert a mucous membrane graft or a hard palate graft in between the scarred tarsal plate Upper eyelid is everted and the scar tarsal plate is incised along the entire length, and dissection is done in below the tarsal plate, and the extent of the gap is measured, and mucous membrane graft, here I have taken mucous membrane graft from the lip, which is sutured in the defect created, and then lid everting sutures are taken from the posterior part, and it comes out just above the lash line. 2 such sutures are taken, and we should use a bandage contact lens so that the sutures don't rub on the cornea during the post-operative period. Absorbable knots are taken so that they don't rub on the cornea, and both edges of the suture are taken out from the skin side just above the eyelashes and tied over bolster. This is a pre-operative picture, and you can see the scarred tarsal plate, and this is in the immediate post-operative period and 1 month later and the subsequent follow-up. Ectropion of lower eyelid is also something which is very common. We should look for etiological factors. Is it congenital? Is there a scar pulling the eyelid away? Is there facial asymmetry, or is it a senile ectropion? We should check for the location of the ectropion. For example, is it medial, lateral, or total? The severity of the ectropion to be noted. Is it mild, or is it severe or total ectropion? And understanding the etiology would determine what treatment will be required for correction of the ectropion. Lateral tarsal strip is a very common procedure which could be used for correction of ectropion, entropion, wherever there is horizontal lid laxity, and it corrects the pathology, that is lengthening of the lateral canthal tendon. And here's a short video. Lateral canthotomy and cantholysis is done. You can see that the canthotomy is being done now, and the lower eyelid is freed. Lateral canthus is freed, and incision is given in the gray line to separate the anterior and posterior lamella. The posterior lamella is shortened adequately to correct the horizontal lid laxity, and suture is taken from the tarsus to the periosteum of the lateral orbital rim. The other end of the suture can be passed through a free needle, and as the knot is tied, the lower eyelid is shortened and tightened. The anterior lamella can be adequately excised. The lateral canthus needs to be reformed. In case there is punctal ectropion, medial spindle operation needs to be performed before lateral tarsal strip. Excision of diamond of tarsoconjunctiva is done just below the punctum, and plication of lower lid retractors can be done during closure of the diamond. In case of cicatricial ectropion, if it is a linear local shortage of skin, then Z-plasty and BY-plasty is sufficient. If there is generalized shortage of skin, then full thickness skin graft, most commonly from the post-auricular area, is needed. Here's a short video showing the same. This is a video showing cicatricial ectropion of the lower eyelid. Here the incision is being given 2 mm below the lash line. The scar tissue is excised fully, and the defect in the lower eyelid is measured both horizontally and vertically, and 20% more of that is excised from the post-auricular skin, and that skin is sutured edge to edge in the lower eyelid, and one end of the suture is kept long, and all the sutures are tied over a bolster, and that bandage is kept for a week. In case of paralytic ectropion, the effect of lower eyelid tightening is estimated on slit lap. Lateral tarsal strip procedure suffices, along with medial spindle operation. Lateral tarsorrhaphy and medial tarsorrhaphy is also a good option. Lubricants for exposure keratopathy and additional procedures for lag ophthalmos may be needed. To conclude, entropion and ectropion are quite common. Various surgical techniques are mentioned. History, clinical examination, and knowledge of surgical anatomy helps decide the best treatment. Thank you for patient hearing.
Thank you, Dr. Mopia, for that wonderful lecture. I think we have come to the end of the session. Do we have any questions? Dr. Sukhdeep, anything to add?
No, Dr. Chinmay, it was a wonderful session.
Okay, I think we will conclude the session. Thank you, Dr.
Yes.
Ishan Acharya, for being with us here for this long hour. And we look forward to have you more in our sessions. And I thank all the speakers, Dr. Vinay, Dr. Smita, Dr. Sudeep, Dr. Raksha, and Dr. Mopia. Thank you very much. And we conclude the session on time. Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you.
Thank you.
Thank you, madam.